go to section 2 of test taking. Okay, so how to study and references. How to study. Try to associate what you learn with past experiences to anchor them, like patient encounters, to enhance retrieval of facts, like hyperparathyroidism. I had Mrs. Jones who had hyperparathyroidism. Her calcium was high. We used drugs to minimize that. We didn't give her vitamin D. So just remember things related to a patient you've had, because most of you have had years and years of patient experience. Focus when you study. You're more likely to remember facts, and when you start to fry your brain, go for a walk or do something else. When I studied for the headache boards, I had my own apartment, and I took a month off, and I would study 4 or 6 hours, go for a walk, study 4 hours, sleep, study 4 hours, eat, study 4 hours, sleep, study 4 hours. And so I would just study off and on in intervals until my brain started to not work, and then I'd do something else. Study high-yield information, not just anything you can find, so like this board review course, books, other things that are focused on the exam. High-yield information, the ACLS manual is good for cardiology stuff because 10% of the exam is cardiovascular. The modules have very good, the lectures here have very good information for cardiovascular stuff. I reviewed them and they seem to be very updated and good. I would look at the ACLS rhythm questions on their website. So on the website for ACLS recertification, they have some rhythm questions. I don't remember if you have to take the course to be registered. I think you could just see them, at least used to be able to. ATLS, less so. PALS or neonatal, maybe if you're doing the peds section. I'll think a lot about cholinergic and anticholinergic pharmacology. There's lots of questions on those. There's lots of questions on pharmacology in general. We talked about that. If you're going to take the geriatrics section or you didn't score well on that, then look at a geriatrics book or manual separate, because the questions there, they try to make things that are right in geriatrics and wrong in general medicine. Then the SAMs, the ABFM things, any of the SAMs that you've taken for your recertification, you can go back and print those out. So you can go back and look at the answers and the questions and answers from that, and that's a good thing to study for cardiovascular stuff in particular and for pulmonary. So CAD, CHF, hypertension, I think there's an asthma and a COPD one. So those two things are both 10% of the exam, so I would think about using those. Learn the drugs, learn the side effects, learn the procedures and their complications. This is a society where there's a pill for every ill and a pharmacologic answer to every question, and some of those questions will come back and bite you on the board exam. How to study. Review the topics several times. Research shows that the majority of people forget more than 80% of what they learned within 1 to 2 days unless it's reinforced and repeated within a reasonable time frame. Don't study more than 3 or 4 hours at a stretch. Split it up even better into 1-hour intervals to optimize attention. Exercise some if you're able to, but not too intense. Some people like study groups. A lot of people find them distracting. So what do we do to reinforce things so that we learned it, and how are we going to keep it in our brain? So before we get to that, I'm going to tell you that I think you should try to get 7 hours of sleep a night when you're studying. I think you should not use alcohol. I think you should, unless you have some reason you have to be on them chronically, you shouldn't take benzodiazepines and narcotics, because all of those things impair memory and incorporation. And then no fun? Okay, you're going to have some fun, but not too much fun. How to study. You need more studying if you scored below the 50th percentile on in-training exams or in general. If you always sort of struggled with test taking, don't focus on recent journal articles and findings. In the last 6 months usually is too recent to be on the board in terms of working their way through the process and them thinking it should be worked into clinical practice. The board doesn't test controversial issues or new breakthroughs until they're more proven. Who are you and where you are? So what is your practice like compared to the breadth of the exam? So if you're practicing just sports medicine, you're going to need to study a bunch of these other things. If your practice is general family medicine, especially if you're in an academic institution where you're getting charts from the specialists all the time, then less trouble. Ask yourself the question, why didn't you become a pediatrician so you could take their open book board recert exam? Is your practice specialized? Are you missing some developments? Are you part of an academic institution? So these things actually help you remember. It may seem stupid, and if you live with your family, they may think you're wacko, but saying things out loud increases your ability to remember them. And then writing them down, that's what I did in college. Every time I had a list of 50 key things or 100 key things I needed for exam, I'd write them over and over again. So that activates different pathways in your brain and makes them remember them rather than just looking at them. So you could even make them into a song, and then when you're in the psychiatry ward, I'll come visit you. Okay. So quartiles, checks and balances, the exam is scored by quartile. If the top quartile misses the question, then it gets looked at and often tossed. Trust your own database. If you haven't been in practice for a while, think of what you saw in the wards, what your whole group does, what you see when you cross-cover for your partners. Unless you're on the wards at a tertiary hospital that just specializes in something, you'll mostly be seeing general medicine. Which is more common, multiple sclerosis or amyotrophic lateral sclerosis? Well, if you're in a group of 5 family medicine docs, you probably know that you got 3 or 4 MS patients and maybe you had one person who died of ALS. And so you can just use that database from your own practice plus your common stuff. Or how many people during your residency did you cross-cover for that had MS versus ALS? So you have that data, you just don't know you have it. But if you trust your instincts and think about what you've seen in your groups and think about what you've seen in your practice, a lot of that information is accessible to you. Then mapping the territory of the exam, so the subject of the questions, the answers to the questions, and the distractors. Those together represent a good map of the sum of representation of what you want to know about a subject for this year and for next year and for the year after it. So for each of the identified topics, how do you diagnose it? Lab imaging, special testing. How do you treat it? Pharmacotherapy, first, second, maybe third line treatments, and procedures. The risks and side effects of each treatment. The natural course of the illness. What happens if it's not treated? How long do people live with this cancer? What kind of side effects do people with lupus get? Epidemiology. Who gets it? Age, gender, ethnicity, specific kinds of risk factors. Pattern recognition. There are separate things that you just recognize as classic appearance or a pattern to something. So like a green stick fracture, a fat pad sign, which is bleeding into the joint, usually at the elbow, a hot bone scan that lights up, hypochloremic metabolic alkalosis, when you have persistent vomiting from pyloric stenosis or another reason. Apparently marijuana is another thing that causes persistent vomiting. I think I had one patient who had that, the GI docs figured out. Aunt Minnie's. So what's an Aunt Minnie? It's like, how do you know something? How do you know your Aunt Minnie? Because she looks like Aunt Minnie. So purpura. Purpura looks like purpura. Lyme disease. Centrally clearing rash with a sort of raised, almost vasculitic looking border. Iritis is perilimbic conjunctival injection. Calcific tendonitis, little spot of calcium, usually at the shoulder. Bowel obstruction on a plain film. 6 loop, 6 or more air fluid levels. Aortic and nasal drainage with a skull fracture. Think epidural hematoma from middle meningeal artery. Paget's disease of the skull, sort of punched out lesions all over the skull that also could be metastatic disease. Free associate. So when you're trying to learn and study, you think aortic and nasal discharge of the skull. Oh, that's we see that with a skull fracture in the temporal bone. What other kinds of diseases do you get in the temporal bone? You might see something like Paget's disease, which maybe 6% of people could have. Ask yourself, is this the right scope for a practicing family physician in the specialty in general or in the module exam? So an interested practitioner active within the field of OB is going to know a lot more OB than people who haven't done it for 20 years. And so you might get a couple of those questions on the general exam, but if you think, I think I'll just take the OB exam because I kind of like that, it's like, maybe not. Be systematic. Think about diagnosis, lab, imaging, special testing when you study. Think about treatment, first, second, and third line. Emphasize pharmacology. What to study? Study the drugs used to treat the condition, study the side effects, study the complications of the procedures used to treat the condition. Good luck on the exam. I wish you all the very best.